So the day before yesterday, we had the privilege to present the results of the SANO trial here at the ESMO Congress. We see that the standard treatment for esophageal cancer is neoadjuvant chemoradiotherapy followed by an esophageal resection. But we also know that an esophageal resection is a major surgical procedure resulting in mortality, morbidity, and a decrease in health-related quality of life. And we also see that after neoadjuvant chemoradiotherapy, nearly 1/3 of the patients have a pathologically complete response, which imposes us with a dilemma whether or not all patients need standard surgery after neoadjuvant chemoradiotherapy. Or should we be willing to perform an organ-sparing active surveillance strategy for patients who respond well to neoadjuvant chemoradiotherapy? So that was the aim of the current study, where we compared neoadjuvant chemoradiotherapy followed by active surveillance versus standard surgery for patients with locally advanced esophageal cancer. We performed a phase 3 cluster randomized trial and included patients who underwent neoadjuvant chemoradiotherapy according to the cross regimen, which consists of paclitaxel and carboplatin. And then we randomized, according to a cluster randomized fashion, the patients to active surveillance or standard surgery. And all patients who were included had a clinically complete response, which means that we couldn't detect any vital residual tumor cells 12 weeks after the completion of neoadjuvant chemoradiotherapy, using endoscopic bite-on-bite biopsies, endoscopic ultrasonography, and PET-CT. We included 309 patients in total. The primary endpoint was overall survival, and the secondary endpoints included disease-free survival, operative and pathological outcomes, and health-related quality of life. I think the major findings are concerning the primary endpoints of overall survival, that patients undergoing neoadjuvant chemoradiotherapy followed by active surveillance had a non-inferior overall survival at 2 years compared to patients undergoing standard surgery. And the same was true, at least for the statistical significance for the disease-free survival and the distant metastasis. So we saw that there was no statistical significant difference in disease-free survival or in the rate of distant metastasis between those two groups. Patients undergoing active surveillance had a better health-related quality of life 6 and 9 months after the completion of neoadjuvant chemoradiotherapy compared to standard surgery. Finally, we believe that nearly 1/3 of the patients have a persisting clinically complete response and thus have benefit from this active surveillance strategy and could avoid a non-beneficial oesophagectomy. So those are the results summarized for the study.